anesthesia for awake shoulder arthroscopic surgeries. Now, what is awake shoulder arthroscopy? Awake shoulder arthroscopy refers to diagnostic or therapeutic arthroscopic procedure on the shoulder performed under regional anesthesia, commonly interscalene or combined nerve blocks, while the patient remains awake or under minimal sedation, thereby eliminating the need for general anesthesia, airway instrumentation, and mechanical ventilation. Now, coming forward, what shoulder joint anatomy and innervation. Shoulder joint is formed by the two joints, that is acromioclavicular joint and the glenohumeral joint. And the muscles which are attached to these joints are supraspinatus, infraspinatus, teres major and minor, subscapularis, deltoid, biceps, triceps, pectoralis major and minor, latissimus dorsi, and coracobrachialis. So basically, shoulder joint is having a vast innervation from C3 to almost T2. So main nerve supply of shoulder joint is by suprascapular nerve, that is C5, C6, which is a branch of superior trunk of the brachial plexus. Axillary nerve, which is terminal branch of brachial plexus. Nerve to subscapularis and lateral pectoral nerve. Now, innervation of the anterior and posterior shoulder. Mainly suprascapular and axillary nerve supply the anterior and posterior shoulder, or the almost 70 to 80% of the shoulder is supplied by suprascapular and axillary nerve. Now, suprascapular nerve is mixed motor and sensory nerve, which provides motor innervation to supraspinatus and infraspinatus muscle and sensory innervation to acromioclavicular joint, glenohumeral joint, and ligaments. Axillary nerve is mixed sensory nerve, providing motor innervation to deltoid and sensory contribution to glenohumeral joint. Subscapularis and lateral pectoral nerve involved in the sensory innervation of the joint. Now, innervation of the skin over shoulder and clavicle. So basically, skin is supplied by supraclavicular nerve, which are medial, intermediate, and lateral. Lateral, these are from the superficial cervical plexus and mainly formed by the C3 and C4. Cutaneous innervation, as I told you, primarily from branches of the brachial plexus with minor contribution from thoracic nerve roots. Supraclavicular nerve, C3, C4 supplies the tip of the shoulder or cape of the shoulder. Axillary nerve supply over the lateral aspect of the shoulder. Intercostobrachial for cutaneous innervation of the axilla and medial aspect of upper arm. It mainly forms from the second intercostal space. So, regional anesthesia for shoulder surgery must therefore result in anesthesia of the following: suprascapular nerve, axillary nerve, nerve to subscapularis, lateral pectoral nerve, supraclavicular nerve. So, mainly from C3 to T1 to T2, we have to cover to block the shoulder joint. Shoulder nerve supply, as I explained to you, this is the cutaneous or sensory nerve supply, as discussed in previous slides. Same shoulder, this is motor and sensory nerve supply. Mainly, if you see root value, they are supplied by C5, C6 and C7. So before going to the how I give the blocks and all, we have to see the brachial plexus anatomy. If you see the roots, C5, C6 root join the superior trunk, and from that trunk, we can see the suprascapular nerve is coming out. Long thoracic nerve and dorsal scapular nerve also comes out from the C5, C6. Interscalene block is given at the level of C5, C6, C7 roots. Superior trunk block is given at when the C5 and C6 joins before the suprascapular comes out. At that level, we have to give the superior trunk block. A supraclavicular or subclavian perivascular block we give at the level of trunks and divisions. Infraclavicular block or costoclavicular block we give at the level of cords. And supraclavicular or subclavian perivascular block we give at the level of trunks and divisions. Now, what are the anesthesia goals for shoulderscopy? We know optimal analgesia, optimal muscle relaxation, patient comfort and cooperation, early recovery and discharge. If you see this 100 or 20 years back, that person can hit that fellow who was posted for operation, and we will get the all goals except early recovery and discharge. Now, what are the choice of anesthesia? Shoulder arthroscopy. General anesthesia with regional anesthesia, or regional anesthesia with mild sedation. Now, why general anesthesia is preferred? It is most predictable method of achieving adequate airway protection and patient relaxation. We get amnesia, analgesia, autonomic sensory blockade to noxious stimuli. But what are the challenges or limitations of the general anesthesia? Patients coming for shoulder arthroscopy are generally elderly, obese with comorbidities such as diabetes, hypertension, ISD, hypothyroidism. Because of these factors, there is an increasing trend of difficult airway. In cardiopulmonary complications, intubation and extubation stress, barotrauma of lungs, bronchospasm, laryngospasm, upper airway abrasion, injury, increase intraoperative and postoperative opioid use, longer post-anesthesia care unit stays, intensive care unit transfer. General anesthesia with regional anesthesia. Actually, I have been doing shoulder arthroscopic since last 3 years. Initially, when I joined, I used to give general anesthesia with interscalene block. I used to give 0.25% bupivacaine, just 10 ml interscalene block. But then why we moved to regional anesthesia? Actually, recently I had came across one case where there was a patient came to us. She was having myasthenia gravis and she was having severe myasthenia gravis, but it was very well controlled with the help of pyridostigmine. From that day onwards, we did that case under interscalene block with supraclavicular block, almost 20 ml volume used, 10 ml for interscalene and 10 ml for supraclavicular block, and little bit local infiltration I had given over the tip of the shoulder. That patient, that surgery went very well, and we could get confidence that we could do such cases under regional anesthesia. Our surgeon was cooperative, and since last 4 months, I have done almost 40 to 45 cases under regional anesthesia. So when I joined this hospital, I gave interscalene block to one patient and block acted very well. But eventually I could not intubate that patient because of the larynx was very anterior and bougie wasn't proper. So I could see the vocal cord, but I could not pause the bougie. So I couldn't intubate that patient. That patient gave me a lot of trouble because already I had given him interscalene block. Because of that, already the hemidiaphragmatic paralysis has happened. And then I could bring him back without any complication. So this was also one of the reasons that we have moved to the regional anesthesia. Now, interscalene block is the gold standard for shoulder surgeries. Indication, shoulder and upper arm surgery, surgery of the clavicle, transducer position, transverse on the neck, just 3 to 4 centimeters superior to the clavicle or the external jugular vein. If you can see in the above image, patient is in transducer position, you can very well see a local anesthetic spread around C5, C6, C7 nerve roots of the brachial plexus between the anterior scalene and middle scalene muscle. Local anesthetic around 7 to 15 ml is more than enough. I generally give only 10 ml of drug. Sonoanatomy of brachial plexus, you can see the C5, C6, C7 roots between the anterior scalene and the middle scalene. And near to the middle scalene muscle, you can see the long thoracic nerve and dorsal scapular nerve which gets away from the C5 and C6. You can see the vertebral artery and just medial to the anterior scalene muscle, there is a coronary carotid artery and our internal jugular vein. Brachial plexus of the interscalene level is seen lateral to the carotid artery and internal jugular vein between anterior scalene and middle scalene muscle. So prevertebral fascia, superficial cervical plexus and sternocleidomastoid muscle, you can see the superficial to the plexus. So transducer is moved in the proximal distal direction until 2 or more of the brachial plexus filaments are seen in space between the scalene muscle. Brachial plexus is generally visualized at depth of 1 to 3 centimeter only. Now I would like to show the video of the sonoanatomy of interscalene block which I had taken this. So see, this is actually at the level of clavicle, just above the clavicle. This is a subclavian perivascular. You can see this is a subclavian artery and this is a brachial plexus superior lateral to it. So I will be moving proximally and medially to see the interscalene groove. So this is supraclavicular plexus, subclavian artery, going just little bit medial and proximal. If you see the position of the patient, I have tilted the neck to the opposite side so that I could get more space for giving the block, and just below is beneath the shoulder. Now I am moving proximally. Now you can see this is the anterior scalene muscle. This is the middle scalene muscle and this is the interscalene groove and C5, C6, C6 and C7 roots. Mostly this will be the phrenic nerve just near to anterior to the anterior scalene muscle. Now if you can see, this could be the long thoracic nerve and dorsal scapular nerve here. This is vertebral artery. Now if you can see interscalene block, we give at the C5, C6 level. And if you see the distribution of the interscalene block, it doesn't cover the C8, T1 or ulnar aspect. Interscalene block distribution, inferior trunk C8, T1 is usually spared. Interscalene approach to brachial plexus block result in reliable anesthesia of shoulder and upper arm. Supraclavicular branches of brachial plexus supplying the skin over acromion and clavicle are also blocked due to proximal and superficial spread of local anesthetic. Now, how I do interscalene block? Position for block, patient in supine position with neck rotated on opposite side and pillow beneath shoulder. Now, how I do interscalene block? I generally do UHG with PNS guided block technique. Linear transducer probe is kept above the clavicle to see subclavian artery and brachial plexus superolateral to it. UHG probe is then moved proximally and medially to see anterior and middle scalene muscle and C5, C6, C7 nerve roots in interscalene groove. Now I give volume and concentration. I give just 10 ml of local anesthetic is injected after getting deltoid stimulation with finger extension or flexion on PNS. So actually on PNS, deltoid stimulation with finger extension or flexion is ideal that you are properly on the C5, C6 nerve roots. 10 ml of local anesthetics only I use, of which I use 0.5% of bupivacaine 5 ml and 5 ml of 2% injection lignocaine adrenaline. And to block the inferior trunk or C8 T1 level, I give 10 ml of same drug at the corner sprocket so that the ulnar aspect also get covered. Now I just generally wait for 10 minutes because if we ask patient anesthesia alay ka, tumhala janotay ka, then patient gets anxious and all these things. Just wait for 10 minutes and always use 10 ml of syringe only. If you are using 20 ml of syringe, unnecessarily we give more drug. So 10 ml is more than enough, 10 ml enough. Check motor and sensory action all over shoulder, local anesthesia infiltration over posterior port or the tip of the shoulder if required. Now I just want to show the video of how I give the block using UHG and PNS guidance. You can see the interscalene groove and the traffic light signal sign. Okay, now see here, I'm gonna give out of plane interscalene block. Let's see how we get the stimulation. So you will see the deltoid stimulation with. So you can see the stimulation here. Reduce to 0.2. Okay, aspirate and inject. Spirit in 90 degree. You can see the spirit of the drug near C5 and C6. So we can see the spirit of the drug in the interscalene groove. Now patient position after block. After confirming the block action, patient is kept in lateral position with arm elevated. So basically we keep arm like this. That's why also I give supraclavicular block. Before taking patient in operation theatre, we make sure patient has passed urine and has been given antacids and antiemetics. I give generally injection midazolam 1 gram and I start the dexmed infusion with 20 ml syringe pump. Monitoring standard ASA monitoring, blood pressure, SpO2, ECG, heart rate. ETCO to probe I generally keep in our Hudson mask at 6 to 7 liter I give oxygen so as to get assessment of the breathing of the patient. Patient is draped properly as shown in figure. Now positioning and irrigation pressure. So this irrigation pressure plays very important role in shoulder scopies. This is the pressure at which the normal saline goes into the shoulder joint. So 30 mm of Hg is the minimum pressure actually so that the shoulder doesn't swell up much and the patient doesn't have any problem afterwards. So intraoperatively, generally our surgeon is very cooperative. He doesn't complain of surgical field and patient also remains comfortable. Irrigation pressure generally required is 30 to 60. Patient and surgeon cooperation must to do awake shoulder scopy. If patient is anxious, uncooperative, then it is very difficult to go ahead with the awake shoulder surgeries. Post-operatively, patient is very much awake, pain-free compared to general anesthesia. We ship patient directly to room and break NBM after 2 hours. This block helps us to achieve all anesthesia goals. So complication of interscalene block. So no anesthesia is without risk. Hoarseness of voice due to recurrent laryngeal nerve block. Horner syndrome due to seepage of drug to the stellate ganglion. Superior laryngeal nerve. Now ipsilateral hemidiaphragmatic paresis due to phrenic nerve is very common. It is almost 100% phrenic blockade occur even if you give 5 or 7 ml of drug also if you are giving, still it will happen. However, very important point to consider, this rarely presents a problem clinically and most patients are not even aware of it. Paradoxical basal gyrus reflex, bradycardia and hypotension. I have seen this patient also while giving block. For this reflex to prevent, patient should be hydrated and it can be treated with atropine and ephedrine. Epidural spinal or intravascular injection, nerve injury or infection. Most of the complication will occur if you are giving more volume. If you are restricted to 8 or 10 or 12 ml maximum volume, you will not see this type of complication. These complications are directly related to the volume of the drug you are using. How to prevent interscalene block complication? UHG with PNS guided block reduce the volume of local anesthetic. Higher the volume used, higher the incidence of complication. UHG with PNS increases the success of block. I generally give, initially I used to give with UHG only, but I then moved to PNS because you will see the lot of variation, anatomical variation at the C5 C6 level. Sometimes the C5 root is somewhere near to the anterior scalene and all. So this will give you 100% that you are stimulating proper muscle, proper nerve root. Proper patient selection is must. Claustrophobic, uncooperative patient can give you trouble intraoperatively. You can give low level of interscalene block. Block should not be given to respiratory compromise or hemidiaphragmatic paresis patient. Now, what are the GA versus regional anesthesia? In general anesthesia, we require ET tube or LMA. Regional, no airway instillation, spontaneous breathing. Analgesia, short-lived, require multimodal analgesia. In regional, it's excellent and prolonged. Hemodynamics, fluctuation, hypotension. Because of the sevoflurane which you are using, it causes vasodilatation. Even if your BP is 160, surgeon still complains that there is bleeding is happening. But even in this, in the regional anesthesia, even blood pressure is around 130/80. Surgeon is comfortable. This is our surgeon's view and our view. It might differ to other people. GA related such as PONV, sore throat, intubation, extubation stress, and in regional anesthesia there is phrenic palsy. Recovery is kind of delayed in general anesthesia but faster in regional anesthesia. Patient comfort is patient unconscious in general anesthesia, but in regional anesthesia it requires cooperation. There is a definitely higher cost for general anesthesia compared to regional anesthesia. Now, patient perspective, I just want to show you. This was the patient I had done just on Monday, and with his due consent, I have taken this video. This patient had underwent shoulder scopy on left side at Safdarjung Hospital, Delhi, under general anesthesia. He was little bit anxious and claustrophobic patient, but still I could convince him that we will do under regional anesthesia, and he cooperated well. Just listen to his perspective.
सर, आपका कैसा था ओवरऑल एक्सपीरियंस ये रीजनल एनेस्थेशिया में जो हमने से ब्लॉक में जो केस किया है उसका?
एक्सपीरियंस अच्छा था और जो उसके नेगेटिव्स होते हैं जो उसकी जनरल एनेस्थेशिया के वो पहले फील नहीं हुए, पेन नहीं हुआ, नमनेस थी, थोड़ा टाइम लगता है आने में। नमनेस पहले लग रहा था कि मुझे नहीं आ पाई, पर धीरे 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 सेंसेशन उधर चली जाती चलेगी। इट वाज ओवरऑल गुड एक्सपीरियंस।
ये लास्ट टाइम आपका जो ऑपरेशन हुआ है शोल्डर का जो दिल्ली में हुआ था, वो आपको पूरा बेहोश किए थे, बराबर? तो उसकी कंपैरिजन में अभी आपको कैसे लग रहा है?
उसमें ब्रीथिंग का बड़ा इश्यू हो जाता है, उस टाइम भी हो रहा था।
अच्छा,
जब मैं मुझे होश में आ रहा था, मुझे उधर टैप कर रहे थे फेस पे, वो होता ना वो की जो बीपी वगैरह वो ज्यादा शॉर्ट अप कर गया था उससे ना, ब्रीथिंग फास्ट वगैरह।
अच्छा,
तो इस बार वो नहीं थी, नॉर्मल सांस ले रहा था। उस टाइम पे वो ऑक्सीजन मास्क से लेना पड़ रहा था, तो ये वाला ज्यादा बेटर हुआ, पेट्रोल
ओके, चलेगा सर, थैंक यू, थैंक्स अ लॉट,
थैंक यू।
Now this is patient recovery. He was shifting himself bed to trolley.
आप शिफ्ट हो जाएंगे इधर, आप खुद उठ के आ जाइए, कोई प्रॉब्लम नहीं, धीरे धीरे आ जाइए।
The patient was completely awake and he could move on his own.
धीरे आ जाइए।
Now, as we all know, interscalene block causes 100% phrenic nerve blockade. Now, what are the options for phrenic nerve sparing strategies? So, there is a STB, means superior trunk block, combined axillary and suprascapular nerve block, combined infraclavicular and suprascapular nerve block, costoclavicular nerve block. Now, superior trunk, as I told you, superior trunk block is done at the level of C5 C6, where C5 C6 meet, but before the suprascapular nerve gets out. Advantage of this superior trunk block is that because the phrenic nerve is located very far, the chances of hemidiaphragmatic paresis are less. Now, suprascapular nerve block, as we know, C5 C6 is the main branch which supplies the anterior posterior shoulder. So, sonoanatomy, if you can see, trapezius muscle, supraspinatus muscle and suprascapular nerve and artery lies deep in the suprascapular fossa. Axillary nerve block, this is not the axillary block we give, this is the axillary nerve block for the shoulder surgeries, which axillary nerve supplies the lateral part of the shoulder, and it is given at the posterolateral side of the shoulder. You can see the fascia formed by the deltoid muscle and teres minor muscle, and in that fascia lies the axillary nerve and posterior circumflex humeral artery. Local anesthesia deposition here will give the axillary nerve blockade. Infraclavicular block position, you can see position supine, and we can see pectoralis major muscle, pectoralis minor muscle, and lateral cord, posterior cord, and medial cord just surrounded by axillary artery. Axillary vein lies little bit medial, and this is a costoclavicular block. We can see the lateral cord, medial cord, and posterior cord. Now, this is one of the very important slide I could get from one good article. Novel regional anesthesia techniques for shoulder surgery. If you consider superior trunk block, full surgical anesthesia possible, yes. Efficacy versus interscalene block. Incidence of hemidiaphragmatic paralysis is 4.8 to 26.7%. Then suprascapular nerve block and axillary nerve block, full surgical anesthesia is not possible. Pain efficacy versus ISB is inferior. Infraclavicular block along with suprascapular nerve block, full surgical anesthesia possible, yes. Efficacy versus interscalene block similar but slightly higher morphine consumption at 24 hours, 0 to 3% chances of SDP. And costoclavicular block, surgical anesthesia possible, but I am not in, like, my views about the costoclavicular block are different. Now coming to the superior trunk block, Kim and colleagues compared STB to ISB in randomized trial of 126 patients. They have found non-inferior maximal pain scores in the recovery room, as well as utilizing similar opioid amounts and lower pain scores. STB group had significantly lower risk of complete hemidiaphragmatic paralysis compared to interscalene group. But one more study by Robs et al. Is showing 33% of patients developed complete SDP, with an additional 26.7% of patients developing partial SDP. 38.9% reported dyspnea and 83.3% had reduced breath sounds on exam. So while STB provides similar analgesia with less SDP compared with ISB, there is a still possibility of diaphragmatic dysfunction, which is important to consider in patients with compromised respiratory status. Coming to combined axillary and suprascapular nerve block, as I already told you, selective blockade can be done at the posterior humerus for the axillary nerve and suprascapular fossa for suprascapular nerve. Anterior approach, though I have not tried, but suprascapular nerve can be identified lateral to brachial plexus just below the omoid muscle, and axillary nerve identified in the axillary fossa. Combined axillary and suprascapular nerve block. Now, two randomized controlled trials assess the efficacy of suprascapular nerve block and axillary nerve block compared to this. What the Dheer et al. Reported that 60 patients undergoing arthroscopic shoulder surgeries, they had worse pain control in the immediate postoperative period with SSNB compared to ISB. However, SSNB ANB provided better pain control at 24 hours. Opioid consumption was also higher in that group. Newt et al. Also demonstrated the same results. Now, the combined axillary and suprascapular nerve block limitations: incomplete analgesic coverage, ignores contribution of lateral pectoral, subscapular, and musculocutaneous nerve. In both RCTs, patient received general anesthesia. So there is a lack of evidence also whether the only surgical anesthesia with the only block is possible or not. As per me, there is no possibility with the combined suprascapular and axillary nerve block to give full surgical anesthesia for awake shoulder surgeries. But yes, for pain relief under general anesthesia, we can use this option with multimodal analgesia. Now coming to combined infraclavicular and suprascapular nerve block, this addresses inadequacies of suprascapular nerve block and axillary nerve block approach. Infraclavicular block, as we know, it targets the brachial plexus at the level of cords from which lateral pectoral, subscapular, and axillary nerve derives. These nerves are missed by suprascapular nerve block and axillary nerve block approach. So infraclavicular block, we are blocking all the cords, and also we are blocking the suprascapular nerve block, and spread of local anesthetics also confined to the below clavicle. So in patient undergoing arthroscopy surgery by this block, as per study, infraclavicular block and suprascapular nerve block resulted in higher pain score in immediate 30-minute postoperative period, small but significant higher morphine consumption at 24-hour compared with ISB. However, there was no one suffered any hemidiaphragmatic paralysis. Study by Pavani also showed that infraclavicular block with suprascapular nerve block group achieved full surgical anesthesia without requiring general anesthesia for arthroscopic shoulder surgeries. Despite encouraging evidence this approach, evidence of SDP in setting of ICB does exist, and 3 to 5% they have still found the hemidiaphragmatic paralysis. Now, what are the limitation of these infraclavicular and suprascapular nerve blocks? First of all, these are very deep blocks. Suprascapular nerve block and infraclavicular block are deep blocks. There are a lot of anatomical variations. Then it requires anesthesiologist expertise, and success of both blocks should be 100% to achieve full surgical anesthesia for awake shoulder. And definitely more volume of drugs is also required. Coming to costoclavicular block is just the infraclavicular block only, perform at the costoclavicular space where the three cords of brachial plexus are clustered together. As per the study, they are told that full surgical anesthesia is possible with costoclavicular block, but I am not getting the point whether suprascapular nerve is not covered in the costoclavicular block. Then how the shoulder gets anesthetized completely? I just want to know that my surgeon's perspective, he is doing arthroscopic shoulder surgeries since 10 years. I am attached to that hospital since 3 years. So let's hear what he says.
So, Dr. Apurva, I just want to know, you have been doing the shoulder arthroscopic surgeries since last 10 years. Recently, we are doing these cases only under regional anesthesia and mild sedation. What is your experience?
The overall experience after avoiding the GA has been very important for the post-operative recovery of the patient. During rounds in the post-operative period, the patients are less uneasy, less nausea, less body ache. They have a better compliance. They are happy after the surgery in a way that they don't feel the side effects of a general anesthesia or any kind of uneasy sensations that they used to have previously. And the recovery in terms of the ability of a patient to go home the next day is far better when a patient is not given a general anesthesia. He feels much more comfortable and is happy to go home the next day. So it truly becomes a day surgery kind of a procedure. And any other setting with such comfort levels, the patient could have been discharged on the same day itself, with the knowledge that the anesthesia is going to last for the next 16 hours without any general anesthesia associated side effects.
So my take-home message: interscalene block is gold standard for awake shoulder surgeries. Lower volume of drug should be used in interscalene block to avoid the complication discussed previously. UHG with PNS improves the success of block. Ipsilateral hemidiaphragmatic paresis due to phrenic nerve is a common finding. It may be present in nearly 100% of patients. However, clinically, this rarely represents a problem and most patients are not even aware of it. Now, I generally give this block out of plane technique. There is a reason why. If you have seen the dorsal scapular and long thoracic nerve, when we are giving this block from the in plane approach from lateral to medial side, so this long thoracic nerve and dorsal scapular nerve can get damaged. So always prefer out of plane block. Now, if giving GA with regional anesthesia, phrenic nerve sparing blocks can be used for pain relief, like superior trunk block or suprascapular with axillary nerve block or infraclavicular with suprascapular nerve block. This will definitely help to prevent the phrenic nerve blockade. Anesthesiologists should decide whether a patient is an ideal candidate for general or regional anesthesia. Patient and surgeon cooperation is key for awake shoulder surgery. Safety of patient is ahead of all. Thank you. These are my references.